Thank you very much for joining today's webinar, brought to you by the New York State Association of Counties and the New York State Association of County Health Officials. My name is Stephen Aquario. I'm the director of the Association of Counties. Why are we here? Well, COVID positive cases continue to be on the rise in a different manner in this state and in this nation. Our governor has re-engaged in this process, but without a state of emergency, the state is leaning on local governments in his public announcements to enact measures to stem the spread of the Delta variant. Yesterday, the governor said, right now, this is all up to local governments. If they don't act, then we'll be where we were last year, where it became a statewide emergency and the state is going to have to act. We scheduled this meeting before those comments were made, but now this gives us the opportunity to discuss how all of you are addressing this fourth wave and to learn from each other as we did through the first year and a half. The American Rescue Plan, which was signed into law by President Biden in March of 21, included $10 billion for states, specifically to establish screening testing programs in K through 12 schools. This afternoon, we'll discuss how interested county health departments can apply to receive a portion of the state's $334 million allocation to help support screening testing in schools within their county. Screening testing is a valuable tool to identify asymptomatic students, teachers, and staff with COVID-19 in counties with moderate to high levels of community transmission. When the federal screening testing funding was first announced, many communities did not have the level of transmission necessary to justify this type of testing, thanks to the tremendous vaccination efforts of our state and local health officials. However, as we've seen in the media and in reports in recent weeks, the Delta variant has led to an increase in COVID cases across the state. As of today, all but one county, Yates, have moderate to high levels of community transmission, according to the federal government. This increase in cases has led to renewed interest in school testing programs to support safe reopenings in the fall. On top of this, yesterday, the state's teachers union issued a statement supporting regular on-site testing in schools as an alternative to mandatory vaccines. Our presenters will share how counties can take advantage of the ELC Reopening School Awards available through the state health department. They'll also explain how pooled and at-home testing can be used to support safe school reopenings. Before I turn it over to Jeanette for some housekeeping announcements, I'd like to introduce the NICE-HO Program Director and NICEAC partner, Christina Dyer-Drobnak, to talk about how schools are preparing for school reopenings in the fall. Ms. Drobnak joined the Association of County Health Officials in 1994. She is responsible for the coordination of the association's core grant activities and supports the association advocacy work. She plays a lead role in the development, planning, direction, and supervision of education and public health leadership programs for all local health departments and local health department staff. Christina also provides technical assistance to local health departments on state health statutes and regulations and legislative tracking and analysis. And I'll say a tremendous and knowledgeable partner with the Association of Counties. We're very fortunate to have Ms. Dyer-Drobnak with us. Christina, what can you tell us about how local health departments are preparing for K through 12 schools to reopen in the fall?
Hi, Steve. Thank you. And we appreciate the opportunity to join you for this webinar. And when I was thinking about this, I think the best way to characterize how local health departments are preparing for K through 12 school reopening in the fall is to really look at the questions that must be answered to assure the success of in-person learning from a public health standpoint. So I'm just going to go through some examples of the types of questions that both local health departments and the schools together are engaged in answering and planning for. And these include things like, what impact will the revised CDC recommendations on masking in the school setting have on current New York State K through 12 guidance? When will that guidance come out, which is the question we all are asking, I know. What should schools consider in their planning for in-person instruction? and the potential need to go to remote instruction based on the revised CDC recommendations on who is considered a close contact in the school setting. Based on last year's experiences and current efforts, do schools and local health departments need to work to revise or streamline contact tracing procedures for when there are positive cases that impact the school community? And then in terms of COVID vaccination, where should vaccination efforts be targeted in advance of school reopening? Where are the pockets of vaccine hesitant populations? What is the best approach for reaching those individuals? Which local providers have vaccine, and what are they hearing from parents in terms of willingness or concerns related to vaccinating that 12 to 17-year-old population that is currently eligible to receive a COVID vaccination? What are trends among local providers generally regarding school-age children being up to date on all immunizations required for in-person school attendance? Are there additional outreach efforts in clinics needed to get children up to date by the start of the school year? How can schools and local health departments assess COVID-19 vaccination rates among teachers and staff as part of their planning? And then specific to the school screening testing, local health departments have been working to identify school needs and capacity as well as their own. So those questions are things like, does their department have the resources to perform the school screening testing? Would the school districts prefer to conduct testing on their own? Is there another organization such as BOCES, and I know we have some BOCES on today, or testing vendors who we'll hear from later, who are better equipped to conduct screening testing? Will the screening testing be mandated by the state, or will, as the governor said yesterday, will this remain a local decision? What are the current trends in COVID transmission rates? How will that impact the existing plans being put into place? And I think most importantly, and I say this as both a public health person as a parent, what are schools hearing from parents in terms of support or opposition to mask requirements? Vaccination of those 12 to 17-year-olds and younger, should that become a possibility, and then screening testing. In the end, both local health department and school plans are going to rely on the willingness of parents and students to get vaccinated and to continue, and in some cases return to those other public health measures that are necessary to either keep COVID transmission rates low or reverse the curve where rates are increasing. So school screening testing can be a valuable tool for reducing the risk of school-based outbreaks, and we look forward to hearing from today's presenters on this topic. Thank you.
Thank you, Chrissy. For some housekeeping announcements, Jeanette Stanziano from the Association of Counties, can you please go over some things for our guests today that are listening in on this webinar here, types of questions, how long we'll go, things of that nature.
Hi, good afternoon, and thank you for joining us for this very well-attended webinar. We will be recording this program today and posting the recording with a PDF of the slide deck on the NYSAC website under Education, and then just click on the Webinars tab, or just type in nysac.org/webinars. We will be taking Q&A at the end of the program. And in order to submit questions, we ask you to do so in writing via your webinar dashboard. Please click on the Questions tab, type in your question, and send it to us, and we will answer it in the order in which it was received in the last 10 to 15 minutes of our program today. We expect this program to run approximately an hour long, and I think that's about it. Everything else is self-explanatory. If you have any questions, you can also contact NYSAC at any time at 518-465-1473 with any further questions. Back to you, Steve.
Okay, thank you very much, Jeanette. We have a great panel of speakers today. I'm very happy that each made some time to be with us today. We're going to start with Travis O'Donnell. Travis is the Associate Director for the State Department of Health AIDS Institute. Travis has been a member of the COVID-19 New York State Department of Health school reopening team since the beginning of the 2021 school year. In his normal duties, he's an associate director in the state's AIDS Institute with oversight over its surveillance, prevention, LGBTQ health, drug user health, and sexual health portfolios, working in public health and community-based not-for-profit sector for close to 20 years. We're very happy, very pleased to have Travis with us. Travis.
Thanks, Steve, and thanks to NYSAC for the invitation to be with you. I really appreciate it. I don't believe I've spoken with you before, so I'm delighted to do so today. Thank you very much. And I just also want to start out by thanking all of you, the counties. You know, since the beginning of this pandemic, increasingly, I think we've seen just the resilience and strength that that counties and local health departments specifically have had in responding. So just a huge heartfelt thanks on behalf of the State Department of Health. Just a quick bit of housekeeping for myself. Since I am a government bureaucrat, I get squirrely about these kinds of things. I understand that there are vendors on the agenda today to speak with you about screening testing. And I just want to make clear that my presence on today's agenda should not be understood to be an endorsement or lack thereof of the products or the technologies that they are discussing. So just by way of a little bit of context, and Steve did a great job of doing this in his opening remarks too, so I'll avoid duplicating that. School is starting soon. I'm not telling you anything you don't know. Your health commissioners and your directors of public health are getting inundated with questions. You're getting inundated with questions, and I just want you to know that I am getting inundated with questions as well. And the State Department of Health does plan to make guidance available. I don't have additional information on what it will entail or the timing of it. And I understand that's creating a high degree of frustration and uncertainty in the field, and I hear it and am committed to working on it. In the meantime, I do anticipate a high level of congruence with the CDC schools guidance. So when I do get questions, I do refer folks to read that CDC guidance. And again, expect to see some similarities, some useful similarities there. And if you've read the CDC school guidance, you, as Chrissy mentioned, there is a large degree of emphasis on promoting in-person schooling, which is great. I'm a father of 3 school-age children myself. My wife is a teacher, so I understand the impact that the last school year has had on everybody. And so it's heartening to see the focus on in-person learning and in-person instruction. In addition, there's a focus on a host of other mitigation measures that will look familiar to all of you, including vaccination. New York State has done relatively well on vaccinations when you look at it compared to the rest of the country. About 57% of the state is fully vaccinated, and almost 70% of adults 18 and older. Almost more than 3/4 of adults have received at least 1 dose. And you know, as we all know, coverage differs across the state. Some counties have higher vaccination rates than others. And of course, we all know that anybody pretty much through grade 6 isn't even eligible yet. So we do still have a large number of people who can't or won't get vaccinated. And to protect people who can't be vaccinated, it's really important to look at mitigation or prevention strategies as a composite, a layering of different prevention strategies, which include masking, respiratory hygiene, cleaning and disinfection, social distancing, and of course, the focus of today's webinar, screening testing, which we're focused on as a mitigation measure that may become increasingly important as we see COVID, really trend in the opposite way we wish we saw it trending, and look to school starting back up, really in a matter of weeks in certain parts of the state. So I think it's useful just to talk about different kinds of testing, because it can be complicated. The state and the CDC do have resources available to talk about the different kinds of testing. It's a some of the information can be kind of esoteric, kind of technical, but I think it's important just for all of us to have a baseline understanding as we go into today's webinar. So I really think of it as 3 sort of buckets: diagnostic testing, screening testing, and surveillance testing. So I'll just spend a minute or 2 going over each one. So the first type of testing is diagnostic testing. And diagnostic testing is really important for symptomatic people, or people who've been exposed to somebody who was diagnosed with COVID. So the type of testing where it's kind of likely you might have COVID, you want diagnostic testing. It's the most sensitive type of testing. In general, results can take upwards of a couple of days to come back. And it's really most useful for like individualized clinical and, of course, diagnostic applications. In all cases of diagnostic testing, the results of that test are reported back to the individual being tested, as well as to public health. So that's diagnostic testing. Screening testing, what we're talking about and focused on today, is a little bit different. And this term screening testing, it's kind of a new term. And it refers really to the practice of testing people for something, even if you don't really have reason to suspect that they have the thing you're testing it for. So people who aren't exposed, don't have symptoms. Screening testing is a little bit less sensitive than diagnostic testing in general, but it has some really useful public health and practical applications. Often the testing is less invasive anatomically. So envision spitting into a tube versus like the deep intranasal cavity swab that you might get with a diagnostic test. So less invasive. Results tend to be available more quickly, sometimes in a matter of minutes. And oftentimes there are fewer demands in terms of space, PPE, et cetera. So there's some real practical benefits to screening testing. Now, just like in diagnostic testing, people who get screening tested have the results reported back to them individually, as well as to public health as per communicable disease law requirements. So there are a couple of other phrases that I think are useful just to have knowledge of. That's surveillance testing and pool testing. So surveillance testing in general is used to get information at a population level rather than at an individual level. So results of surveillance testing in general aren't reported back to the individual who got tested. And for those of you familiar with wastewater testing, you might have it in your county where samples from municipal wastewater are tested for COVID. That's a perfect example of surveillance testing. So like if the amount of COVID that's detected in the wastewater goes up, that tells us something useful about the community transmission rates of COVID in that community in general. It doesn't give us any information about one individual person, but it tells us something useful from a public health or epidemic monitoring perspective. And then lastly, you've probably also already heard about pool testing, which is this practice involves mixing several samples from people together into a pool. And then that pool is tested using a diagnostic lab test. So pool testing is really useful because it increases the number of people who can get tested efficiently and quickly. So it's really useful for testing large numbers of people. Pool testing is often used for surveillance purposes, although there may be companies that offer pool testing where the results are reported back to the individual being tested. And in that case, where the results are being reported back to the individual tested, that pool testing could be considered a type of screening testing. Again, I know it's technical information, and that's why you have health directors and health departments, state health departments, and the CDC to help you kind of wade through all of this. But back to screening testing, the reason we're all here today. So what does the actual CDC guidance say about screening testing? It's a key mitigation strategy for monitoring transmission and protecting the health of unvaccinated people in K through 12 settings. CDC recommends that any school who meets the CDC's definition of moderate, substantial, or high transmission implement weekly screening for unvaccinated students, teachers, and staff. And as Steve pointed out, that's almost every area of the state right now meeting those metrics. And then they recommend additional, more frequent screening testing for high-risk sports and extracurricular activities. And those are all defined through links in the CDC guidance. So really, to be consistent with the CDC schools guidance, schools should be preparing to have this capacity to do this type of screening testing now. As Steve indicated, the state health department received a really sizable $334 million in CDC funds to support this goal of operationalizing screening testing. The city health department also received a separate grant. So we're both sort of in the process of deploying that funding. And just as a side note, I'm really glad that this funding has been made available. Just a few short weeks ago, when we were living in a world where we were sort of all celebrating our victories at vanquishing COVID, we looked at these grants and we were like aghast at the size of these grants and all of this money going into screening testing. But it just goes to show how quickly things change. And I'm really glad that as we're going into this school year promoting in-person instruction, that we do have access to these resources. So what are we doing with the money? We are in the process of hiring folks within the department to oversee the work. And we have also made sizable grants available to local health departments to work with schools to implement screening testing programs, kind of along that line of local control. recognizing the pivotal role local health departments have had last year and will continue to have this year. There have been no requirements for local health departments to accept this funding. The state did not require that, but I am happy to report that every local health department, except for 2 in the state, did accept or intend to accept the funding. So I do anticipate having statewide coverage between BOCES organizations and counties. And at the state, we really, again, appreciate the partnership and collaboration. So right now, local health departments are in various stages of budgeting and work planning. You can ask your commissioner or public health director what phase they are in, or if you have questions about what the plans are that they are developing. And I really, again, $334 million is really an astronomical sum of money. I really feel like we are in a period of unprecedented investment from the federal administration, the likes of which we have never seen before in public health. I've been in public health for 20 years, and the amount of funds that are going into things that we've been saying we've needed for years is really unprecedented. And I know firsthand how uncomfortable it can be embarking on new initiatives with a lot of money behind it when we're used to really a poverty mindset. And I know how uncomfortable it can be doing so in the absence of guidance that we know we need to get out. But again, I just really appreciate the partnership, and I really think that this new initiative has a lot of potential as we move into the next school year. So thank you once again, and I'm happy to take questions now or at the end, whatever NISAC wants to do.
Okay, thank you so much, Travis, and thanks for joining us today. We really greatly appreciate it. We've got 2 speakers to get to here. We'll take questions at the end. We encourage our folks who are listening to us now to type in the chat line questions so that we can get these questions for Travis, for Matt, or for Tom Carey here. Please feel free to send in those questions and we'll get to them at the end of the presentation. Let's go to Matt McKnight, who has the best title I've ever seen. Matt is the Concentric Chief Commercial Officer for Ginkgo Bioworks. Matt leads the Concentric division, focusing on implementing Ginkgo's biosecurity and testing capabilities, in particular, their nationwide K through 12 COVID testing programs. Very pleased that Matt was able to join us. Let's hear from Ginkgo Bioworks. Matt.
Hi, thank you everybody. And Stephen, we really appreciate you making time for us to speak to all the counties here in New York. We're really excited, and I'll just echo one thing that Travis said there near the end of his remarks. We are really in an unprecedented time, and for all of us to be thinking about what we can do to prepare the communities that we are part of for getting our students back to in-person learning, and then thinking about the opportunities after that is something that we care deeply about. Maybe I'll just share just a quick perspective on background. If we can go to the next slide, please. So Ginkgo Bioworks is a Boston-based company operating nationally. We are a synthetic biology company. So like many others, we were kind of thrust into this world back in March of 2020. And we said to ourselves, with the resources that we have in high-end biology, what can we do to help respond? Very much internal conversations were very much like, is this the moment like Ford Motor Company making airplanes instead of cars? What can we do? So we quickly worked on a bunch of different creative solutions, asking ourselves, without a preconceived notion, what were the biggest problems that we were going to face coming into COVID and trying to get ourselves back to regular or something that proxies regular life. And there were 2: vaccines. Obviously, we work on that side in a different part of our business. But really, it was the 55 million K through 12 students in America that needed to be in in-person learning. And so what was really important about that, and if you go to the next slide, please, we have approached this problem since last September in a different way. And this problem being, how do you ensure risk mitigation as much as possible while trying very hard to get our students back into in-person learning? So not being a company that came from a diagnostic testing background, to Travis's great description, not being a company that had any preconceived notion, we kind of flipped the script a little bit and said, schools are hard places. Schools are hard places because they're under-resourced, because they're unique community centers, If schools are going to use a number of tools, with testing being one of them, what type of testing solution will be best for schools to be able to deploy it? Because it's one thing to deliver tests to schools, it's another thing to run a robust program with thousands of students coming every day into the community. And so that's really where we started in September and October, and we asked, what are the unique conditions of schools such that they can use tests appropriately? And two things really stood out, and if you think about it. One is it has to be easy. The whole point of getting students back into schools is so that they are learning. It is not to turn schools into clinics. So we started first, it needs to be easy. This was before the CDC ELC money. It also had to be inexpensive. Schools should be using their resources as much as humanly possible to improve the education of students. Obviously, the federal resources have given more impetus to robust, fully integrated programs, but we also said it needs to be efficient, which we think is just still a good public health principle, especially if you want to use this going forward. And then I think second, we said we really flipped and said, what is testing really doing? To Travis's description, it is not necessarily the kids are in school. Your assumption, because they're doing these other things, they have attestation forms. They aren't coming to school if they have symptoms, because people are much more aware of this. The assumption is that the students are negative when they're in the classroom. If they have symptoms, they should not be there. So we asked ourselves, if that is true, what is this that we're doing? We're generating data. So testing should be a resource for the districts, for the administrators, for the folks making decisions about their schools and the risk of having students in person. So testing, we really think about as a data generator. And so what type of data do you need to be making those public health decisions, to be making those community-wide decisions about how to intervene if you were to have a COVID outbreak or higher levels of COVID in your classrooms? So with all that in mind, we've designed a program that is foundationally with cohort testing or pooled testing. We test everybody in a classroom together as a group in one tube. The students self-swab their own nose. This is not the deep nasal swab, to Travis's point again. This is the, folks can see my video, it's just the lower nasal swab, and we have students down to kindergarten age regularly swabbing their nose, and then they go and place the swab into a larger tube. That cohort is tested all together. And there's two really important things about that cohort being tested together. First, it meets schools again where they are. We organize ourselves in schools into groups, into classrooms, into teams, and we empower the schools with a tool to test those groups that are generally together as one. And then second, what it does is it allows the schools to be empowered with a tool that they can use in their own workflow very quickly. It takes about 8 minutes for a normal size class to run this program once per week, which is generally what we've seen people running them. So that's the foundation. The foundation is testing cohorts of people together. In our nationwide data, we're seeing right now, and this should be reassuring for folks, and through the course of the spring, it's about 1 in 100 or 1 in 150 classrooms, somewhere in that range, depending on where you are in the country and depending on prevalence range, that are positive. So really, when you're doing this monitoring-based cohort testing of classrooms per se, classroom pooling, you are able to very much efficiently find where COVID might be. It is not that half the classrooms are positive. It's a very reassuring data asset for decision makers to use in their public health decision making. If we go to the next slide, please. This program, which I'll go into a little bit more depth, we are now we are operating on a nationwide basis. So to give you a sense, and I'll explain what the program is. It's pooled testing and as the foundation, but then we offer a full comprehensive service that incorporates, based on guidance from the local public health authorities or the state, we make available individual diagnostic testing or other modalities as Travis described, as well as staffing support. We're running, we are the sole provider of the CDC ELC program implementation for the state of Maine. We are one of 3 providers in the state of New Hampshire. We're one of 3 providers in the state of Massachusetts and provided that program all spring. We are also providing the entire statewide program in Arizona. and there's about 4 other states that have that are in the process of contracting. So our entire focus, and maybe I should have emphasized this up front as part of Ginkgo's story being not really, we're not about selling tests, we're about solution-oriented K through 12 testing. The 99% of the testing we do across the country is only K-12 focused, and we've built the program to be laser focused on exactly this problem of keeping kids in their schools. If you go to the next slide, please. This just as a few highlights, which we'll share in the slides later. We included them so you can see we're running the statewide program, as I mentioned, in Massachusetts. All spring we ran Baltimore County, Baltimore City and Montgomery counties in Maryland, as well as a number of districts in California. Next slide, please. We've signed up New Hampshire, Arizona, and Maine, as I mentioned, and we're happy to provide references for any of your counties or any of your districts who would like to discuss how the program has been implemented, and take ourselves out of the loop on that, but introduce you to as many people as you'd like. We find that as a very useful network effect of people just learning from each other. This has been a really hard problem to solve, and we can provide a hub of information, but we've also found that folks trying to implement this across districts and counties and states learn a lot from each other, and we're happy to facilitate that. Next slide, please. This is the detail version of what we provide in our fully integrated program. So this is the fully integrated program that we provide to the states that I mentioned, as well as large districts and counties. Again, our foundation that we recommend and have seen implemented nationwide, I think we've done, we've tested over 1 million students now nationwide, or close to 1 million students nationwide, is the foundation of pooled or cohort testing that's monitoring your baseline level, that's really generating data for decision makers about the prevalence of COVID, either in a classroom or cohort basis, up to the schools, how they implement that, and up to the public health decision makers, how they implement that program. We take another benefit of that, because it is an aggregate test, it's a group test. The schools manage any personally identifiable information. We do not hold personally identifiable information for that baseline monitoring. And then our platform is integrated to provide the other 3 components that you see here in orange, blue, and pink. Some, in many places, having individual diagnostics, either rapid antigen testing or PCR on site, both of which we support in a fully HIPAA compliant manner, is the tool that schools use to, when they have an outbreak or when they have a reason to test a cohort, to use immediately to find positive students and then take interventional action. And then many schools have nursing support, but also we found that obviously schools are staff pressed, and we've built nationwide relationships in each state that we operate in to provide on-site staffing to support the programs. And this is all, again, including the program administration and reporting both to the state and CDC nationwide. This is being funded for us under the vast majority is the CDC ELC dollars that you all will have distributed to the counties. In some places where the ELC dollars haven't been made available as nimbly to the counties as they have in New York, people are using their ESSER funds at the school level. If you go to the next slide, I just have 2 quick detail. This is what the pooled testing program looks like. Very simple, Q-tip-like swabs. The students we can share a number of videos. The students will pull their masks down like they're taking a sip of water, swab 4 seconds in each nostril, put their mask back up, and place the swab in. So there's very little contact with any of the test administrators. It's not something that's administrated by a huge nursing staff. Next slide, please. Again, we offer individual diagnostics on site, PCR or the rapid Buy Next Now cards. That's very helpful when you have symptomatic students or when you're looking to identify where you might have an outbreak in a specific situation. And then the next slide, please. I'll just hit very quickly, cognizant of time, 3 other important things at the school level and the district level, and then the state level, to the extent that the state is interested. We provide live dashboards. Many of our programs, if you think about it on a county or district level, make these dashboards available to the community via their websites or a special website that we can help support that's dedicated to providing insight and transparency into the community. And what this is showing you is essentially every pool you run, think about it as a weather map. Now you've got a school, which is where everybody comes and you're testing once per week, you're monitoring these classrooms. You're able to then communicate back to the community what actual prevalence is as it relates to the schools, something that we find very important to supporting the decision-making processes within communities. The next slide, please. A lot of this whole world, to Travis's point about complexity, has been, oh, I'll build a mega lab and you can ship all your tests to Boston. Well, we don't do that. So just so you know, if you were to deploy this in New York, we have a network of local labs across the country and in New York as well. Our goal is to decrease turnaround time, and what we use our central lab, where I'm sitting here in Boston today, to do is to qualify labs around the country. So our data system is consistent across all the schools we serve, across all those states that I mentioned, and all those districts. So there's shared learnings and shared lessons, but all of the tests are actually run locally, so that helps decrease turnaround time. Also, just to in this world where we've decentralized resources, it also keeps the resources that are being deployed in the state. We found that to be an effective kind of community togetherness tool. You are able to deploy those resources closer to home. Then lastly, I'll just share 4 quick slides about some of the support we provide directly to schools, because this will close on the same place I started. You've got to meet schools where you are. We've seen over and over again around the country the process of trying to get testing up and running in schools. You can provide all the tests you want, but if you don't make it easy for schools, which are hard places to be, and focus on that customer service in the school context, it's not going to work. So we provide a really robust set of tools to help schools implement this quickly and efficiently. So next slide, please. Things like support materials to describe the testing steps so they can post in their classrooms about where the test center or where the test table is, how the kids will flow one by one through the process, and give them instructions on how to set this up themselves or with their staffing support. But it goes beyond that. So if you go to the next slide, please. Part of this is getting kids excited about biology, right? For the first time, we've seen this since October, November when we started this. Kids are excited to be back in the classroom. They're excited to be participating and learning about what they're doing. They're excited to do this test over time. And so we provide comic books and coloring sheets. Remember, to the point, like this is K through 6 and then K through 12 students. And so part of our company ethos is to make biology accessible. So part of this program for us is helping ensure that kids are supported across the learning spectrum. And then lastly are families. And next slide, please. A huge component of this is, presuming most programs are consent based, so the parents need to consent to this testing, is communication to families, and schools aren't equipped to create their own communication to families. So over those millions of tests we're running across the country, we've learned and built an incredibly deep set of materials to share with families on behalf of the schools and the districts to help them get excited about participating. And then I will close, and again, really appreciate the next slide. Really appreciate the time that is offered for us to speak about this. This is really important to us. We've built this program to be nationwide scalable. Equity is very important here. If you're going to provide testing on a nationwide basis, either as a company or as a federal government providing funding, we want to make sure that everybody has the same access to the same tests. And so we've built a system to be scalable, to be something you can deploy very quickly. Generally, we're up and running in a given school that signs up within 7 to 10 days because of all these pre-packaged materials. Everything is put together, focused on the K-12 environment. So again, this is about data generation. This is about providing the information to make good decisions, to keep kids in their classrooms as much as possible in a risk mitigated manner. And we're super excited to have the opportunity to describe this to you today, and would be happy to answer any questions later or independently, and happy to have independent conversations with any of the folks on this call.
Terrific. Thank you very much, Mr. McKnight, Concentric Chief Commercial Officer at Ginkgo Bioworks. Fabulous presentation again. These slides will be made available at the NISAC website, and we'll make sure to post those at the end of this afternoon. Let's hear from Tom Carey of Let's Get Checked. Tom has been working with the association, local governments, education educational programs around the United States and in New York throughout this pandemic. And let's hear from Tom Carey about some of the technology and services that Let's Get Checked can help in this regard. Tom.
Thank you, Steve. And also just to echo Matt and Travis, just to want to give a shout out to the great work that Steve Aquario and NISAC does in representing counties across the country. It's such important work and never more important than this past 12 to 18 months we've been dealing with this pandemic. So congratulations to you, Steve, and your team. I know you guys wake up every morning thinking about how you can take care of your counties and the constituents in those counties, and in this case, the K through 12 students. And as Travis said so well, it's really important to really give these students and their families that peace of mind to come back to school safely. So I've been with Let's Get Checked about a year and a half now. I joined them really to be part of the solution. Let's Get Checked was founded in 2015 to help people with at-home diagnostic testing. And then as many people got involved with testing in this past year, I just really want to be part of the solution. So as we go to the next slide, Let's Get Checked was founded to really empower people to live longer, healthier lives, guided by science, empowered by technology, and passionate about caring for people. And as Matt said so well, caring for K through 12, letting them go back to a safe environment. I know the importance of that. I'm the father of two young, a middle age and a high school daughter, and making sure that they're tested, safe when they go back to school is critical to myself, and I know many, many other families as well. So being part of the solution is really critical to Let's Get Checked. We were founded in 2015. We are based in New York, where we have a manufacturing and distribution facility, so we can get tests out quickly. We've done over 2 million COVID tests this past year, and we're working with states like the state of California, state of Florida, counties all across the country from LA and Ventura. We've done work with Onondaga County, which led to testing for Syracuse University and Lemoyne College. And on the next slide, we were very early to get FDA approval for our at-home test. And just as Travis and Matt said, ours is not the Javelin that you saw on the news and many people had to do in their drive-through testing. Ours is the lower nasal swab. We got early FDA approval to do at-home self-collection. You get your online results. It says 1 to 3 days, but it's generally 24 hours from the time of receipt. We're testing for the COVID PCR. Our shelf life is about 3 to 6 months on these tests. And on the next slide, what we've done is, really, just as Matt said, we can offer either the PCR test or the rapid antigen. But as Travis did so well in pointing out the different tests and different solutions that you're looking for, it's critical to know the difference between the different tests that are available out there. So your PCR test that we offer is a lower nasal swab, the turnaround time 24 to 48 hours, but it's very sensitive and specific. Ours is 99.7%, meaning you're going to, if there's an infection out there, this gives you a very good chance to do that. The rapid antigen, which we also offer, it's for a different type of use. That's more for someone who may have been exposed or thinks that they have been exposed. And the sensitivity is not quite as high. It's moderate. So you can get people who have a false negative, and you've probably seen those in the news. Rapid antigens are very good. It's just you want to make sure you're using them correctly. And I think Travis did a great job of talking about the different times when you want to do different types of asymptomatic testing or symptomatic or screening. Next slide. And Let's Get Checked. As I said, we got early FDA approval, and a lot of companies got into the testing game in this past year. It seemed like everybody was getting involved in one way or another. The FDA did a blind study of all the at-home tests out there on the market and selected Let's Get Checked as the most analytically sensitive at-home test on the market. So what you're looking at on this graph right here, and where it has Let's Get Checked at 720, that gives you the best chance of an at-home test in terms of level of detection. So if you're going to do self-collection and do some of the screening that we've talked about, you want to make sure that you have the best possible chance to detect the virus. And Let's Get Checked test gives you, as detected by the FDA in a blind study, the best chance to identify that infection out there. Next slide. And then, as we talked about today, and the other speakers have, there's a lot of different funding out there that's available. Some of it's going to surveillance, some of it's going to vaccines, some of it's going to sequencing. And pooling is really an excellent way to take those costs that were so high in the beginning of COVID, or getting that cost down to a very manageable level. And pooling allows you to do that where you can have multiple people tested at the same time and then pool that. And on the next slide, we do our pooling a little bit differently. We do ours at a maximum 10-to-1 ratio. We do it back in the lab. But what we do is, it is a very efficient workflow. So the students go ahead and do the self-collection, and you can do that, and it gets pooled back in the lab, and then we can do the individual reporting so that you get the population health snapshot of the entire school, but then you can also break it down to the individual level as well. And we get the results back within 24 hours of receipt of that sample in the lab. And on the next slide, we got very early EUA for testing for minors. So we can do at-home testing through our EUA for minors of ages 2 and up. So 2 through 11, it needs to be observed and done by a parent. 11 through 18, they can do it by themselves. But it's secure activation and results delivery on the app, so the person can see that. I've done the test numerous times, always been negative, fortunately, but it's a very easy to use test. It's that lower nasal swab. It only takes 10 seconds in each nostril. And we are very happy. We've done a lot of work in the state of New York. We've worked with the Wadsworth Lab, so they're familiar with us. We can report back to the school and then behind the scenes to the CDC and to the state, to the Wadsworth Lab, which I know is really important to the state of New York. And on the next slide, what we've done is we've worked nationwide with, doing over 2 million tests, and we've worked with a large state university. We've done Syracuse University, Lemoyne, but also University of Virginia. I just thought it was interesting because they did a very innovative program where they tested people at home before they went to school. So we can actually send these tests to people at home if you want to test them before they came back to school. And what we've done with some of our universities and even K through 12 is tested them at home so that they didn't have to worry about bringing a mass spreader event back to school. And what they found was 98.8% of their tests returned negative, and the average turnaround time of those tests was 14 hours. So you literally couldn't get onto the school campus unless you had a negative test from Let's Get Checked. And it worked seamlessly, and they were very happy. So I know we're pressed for time, but I just want to thank Steve and NISAC and all the counties and the other speakers for allowing us to have some time. And we know that not one company can do all the testing out there, so we're happy to make our services available, and would love to answer any questions you have or speak afterwards. So with that, I'll turn it back over to Steve.
Okay, thanks so much. This is an opportunity for folks to submit questions. Really appreciate it. We approach the 60-minute marker here. I guess a couple of questions here that have come in. We'll start with Travis O'Donnell from the Health Department. Is the state recommending a combination of testing methods for school reopenings, or just screening testing, or comments on the CDC? Your observations, Travis.
Sure. Excuse me. So in terms of having adequate capacity to be ready for school, I think there are two main scenarios that schools should be prepared for. One is you have somebody with symptoms, whether it's a student or a teacher, and you need to get them testing. That person, the best type of testing that would be recommended for such a person who is either exposed or symptomatic would be to get one of those diagnostic tests. Now, as my co-presenter said, not every school is going to be a clinic, and so they might not be able to do that higher threshold diagnostic test. So having a referral source, or being able to have kids go back to their primary care physician if they have one, would be important for diagnostic tests. And then in addition, having this capacity to operate some sort of screening testing program consistent with the funding guidelines would be recommended as well, according to the CDC right now. So having capacity for diagnostic testing and having capacity for screening testing would be strategies that would be recommended.
A follow-up, Travis, to that has come in about the timing of the ELC grants to the counties for the school districts. Is it a one-time grant? Is it a multi-year grant? Can you discuss the funding picture?
Sure. So currently the end date of the ELC School Reopening Fund grant is July 31st, 2022. Now, I am very, very confident that we will have the ability to extend the end date based on savings, cost savings that we realize throughout the year. We can't commit to that right now because the end date is established by the CDC. But again, very, very confident we'll be able to extend that. And who knows what future years of this funding will bring. Again, I think this is an unprecedented time in terms of the investments that we're seeing from the federal administration, and really encourage everybody to get in on the ground floor and hope that this investment continues for years and years to come.
Okay. Let me go to the two company representatives that are with us here, Matt McKnight and Thomas Carey. Do we have your contact information available? We've had requests for information to call you and talk about the various costs of these services for your companies and how they can procure you.
I can go, or I can. Why don't I defer to my colleague first?
Sure. You have my information, but my email is tcarey, TCAREY @letsgetchecked.com. And my phone number is 203-216-0056. Happy to answer any questions, walk you through our different options, and happy to help in any way we can.
Thank you, Tom. Matt McKnight.
All right, I'm going to do the same, and I'm going to give you a long email address, and then we will. I assume there's a way we can post this as well, and share it out to the attendees.
Absolutely. We'll get your contact information and we'll put it on the webinar slides when Jeanette posts this at the end of the day.
And it's on the back of our webinar slides, but I will give you a contact right now. So an easier one than my name is our lead for the entire Northeast. His name is Ben Rome. It is BROME at Ginkgo, GINKGO, bioworks.com. And he even said I could also give his cell phone number. Here you go. 617-947-7378. And he's New York based.
Okay, thank you very much. It's time for a couple more questions. Let's see. I guess staying with Travis, any other settings or to the corporate representatives that are here, any other settings that may use screening testing useful in? Are there other venues, county office buildings, jails type situations? Any thoughts on other venues?
Hey, it's Travis. I'll take a stab. So absolutely. I mean, screening testing for unvaccinated individuals is probably one of what I would consider one of the strongest public health mitigation measures available. In terms of allowability within the CDC ELC school reopening grant, the costs are allowable for K through 12 schools, and that includes charter, independent, privates, school-affiliated summer programs, so camps, school-sponsored events, so book fairs, graduations, sporting events. But absolutely, you know, any time where there are groups of people congregating where vaccination status is either negative or unknown, a robust screening testing program would be just good, solid public health.
And I just add, and I know Let's Get Checked has great experience in this space as well, and really appreciate their work. For folks, so outside of the K-12 focused ELC program, we do think that this tool of using testing to generate data has been a very effective one for a pandemic response. We run programs for workplaces, for nursing homes, for prison populations that have been very effective at least managing outbreaks when you do have them. Otherwise, you're living in a data-free environment, And that's really the mentality change, I think, for us as we think about these different testing modalities. Is this is the first time you've had a major disease that was disconnected between symptoms and your ability to test, and this gives us the opportunity to use it as a data generator. It's been very effective.
Okay.
Yeah, and I'll just agree with Matt. We've done very similar work with drive-through testing for states, for counties, back to work for employers, return to work, and some jail populations as well. So wherever you have a defined population, and the key, I think as Matt said, is make it easy for them, let them understand that it's simple for them to test, and then give them the data so that they can understand and manage outbreaks for people like Travis and others so that they can see, and then you can figure out where you need additional dollars to mitigate that. But thank you again.
Okay, let me just got a couple of quick questions here to wrap up here. The first question is, let me do some rapid fire stuff. Are 100% of the costs associated with the local health department contract with these companies covered by the ELC grant? You want to go to Travis? You want to take a stab at that? Maybe the companies in your experience.
So I can just say in terms of, not specific to any particular company, but, the department as the steward of the CD funds is absolutely committed to making sure that our funding is flexible enough to cover any expenses associated with administering the program. And we know that comes with not just the costs of the sample collection and lab processing, but also the administration. There's going to be fiscal reports. So a percentage of your fiscal officer, your fiscal staff would be needed. Doing the outreach with schools, that's a person, that's time doing that. So absolutely, we acknowledge there are programmatic costs and administrative costs in addition to the nuts and bolts of doing a testing program, and would absolutely be covered by the ELC grant.
Okay, thank you very much, Travis. Do either of these programs do sequencing for variants?
I can jump in. We have substantial capacity to do sequencing of variants if it is something that either the counties, districts, or the state is interested in, and we do that. We do that for both pooled samples, group or cohort samples, so you have a kind of aggregate look across any positives as well as individual samples.
Yeah, and this is Thomas Carey from Let's Get Checked. We have our own CLIA CAP accredited lab, and we're doing some sequencing right now, and we're doing some sequencing in the state of California and in discussion with some of the other states as well. So yes, we can do that.
Okay, we just have so many questions, but we're going to wrap it up with this one question here. I can't get to all these questions. I really appreciate the information, the education that was given us here today. Matt, let's start with you. It looks like there are no approved labs for upstate New York. The map that you used stated that there are in discussions with the lab, it looks like in Rochester area. How will this impact testing turnaround times and availability? And Tom, if you want to talk about any issues with labs that Let's Get Checked is using. So lab capacity to both company representatives.
Great. I'll very quickly. So first and foremost, we have nationwide lab capacity of qualified labs in the region, in particular in New York, as well as very close surrounding states, to supply all 60 million students or 55 million students in America once per week via pooling. We have a partnership with Quest where they can run our back end pooling, so the capacity is not an issue. To the extent that we have significant volume in a region, it takes us between 2 and 3 weeks generally, depending on the lab, to qualify new labs. So we'd be very happy to explore qualifying labs in your local communities if that is something that was of interest to each of the districts.
Tom?
And this is Tom Carey. Yes, so we have lab capacity. Our lab is actually in Monrovia, California, but we provide the shipping to that lab and do the turnaround. And then we also have a partner lab in New York if, for some reason we needed additional capacity.
Okay, so we had a question come in here. Are there template contracts for us to help for our county administrators understand the services we would actually be contracting for on behalf of delivering the services to our school districts. So if anyone has that type of a template contract that you're using through a BOCES or through your county health department right now, if you could send that to coronavirus@nisac.org, coronavirus@nisac.org, and we can help post that on our website. But let me present that question to any of the presenters that are here with us today about potential template contracts that are in use for the scope of services that it's actually being procured on behalf of the school districts.
From our standpoint, short answer, the fully integrated cohort pooling with all of the other add-on, both on-site diagnostics, staffing, as well as reporting. Absolutely, the answer is yes. That's the same program with slight custom modifications based on county, district, or state that we've deployed across the country. That's on the shelf. What we'd actually prefer is if folks are interested, just because we like to hear 2 minutes on the unique conditions of a specific area, and we can provide that very quickly after a short conversation.
Terrific. Well, that will conclude today's session. I want to thank our panelists that were here with us from Ginkgo Bioworks and Let's Get Checked, and certainly Travis O'Donnell. And let me make it perfectly clear again, the state of New York, the health department, or any state agency is not endorsing either of these companies. The Association of Counties, is offering this educational and informational session only, not the New York State Department of Health. But I do want to thank Travis O'Donnell. Fabulous job by all of you. Thank you so much. That will conclude today's webinar. Again, this will be posted on the Association of Counties website at the end of the day. Thank you very much.